Welcome to the smartest doctor in the room. I'm your host, Dr. Dean Mitchell. Today's title is going to be on mast cells and how they affect vaccines, drugs, food allergies, a lot of things, and possibly this new mast cell activation syndrome. It just so happens today's guest and myself are both specialists in allergy and immunology. As my listeners know, I do a whole range of things, but when it hits home, I really get very excited. And today we're going to have a very in-depth conversation on how mast cells, an underappreciated cell, is so important in allergic reactions to vaccines. And we're going to talk a little bit even about the COVID vaccination program, drugs and foods. And we're going to hopefully discuss a newly described syndrome, which I get a lot of calls now from patients about, something called Mast Cell Activation Syndrome, which I think maybe ties a lot of these conditions together. I'm sure a lot of you have heard about B cells and T cells and the importance of the immune system. That's something that the AIDS epidemic really brought out when I trained in the 1990s. And it was what they called the adaptive immune system. I don't get too technical, but that's like your super smart memory immune system. But there's another part of the immune system called the innate, or what we call primitive immune system, which doesn't have memory. And I think for a long time, because I teach this at the medical school, was overlooked. And mast cells are considered a part of that. My guest today, Dr. Mariana Castells, is internationally known as an allergy immunology specialist at Harvard Medical School, where she is the director of both the Drug Hypersensitivity and Desensitization Center. She's also the head of the Mastocytosis Center. So she's what you call a triple threat in our profession. She's a top researcher. She's a well-known clinician, especially with her drug desensitization clinic. And she's really a highly regarded teacher. And the last thing, which I have to mention, there's barely a month that goes by when I'm reading my journals, the allergy journals, the New England Journal, that she's not in one of these journals. So she's very current. So it's my great pleasure to welcome Dr. Mariana Castells to the podcast.
Thank you so much. I'm delighted to be here.
Okay.
And actually, I have to say something that I'm so glad that you're bringing the mast cells to the forefront. They have been the forgotten children of our immune system. So I'm totally grateful that you're thinking about them, that you're thinking they're important, that you're thinking that people need to know more about the mast cells.
What's funny about this, Dr. Castells, is that, again, I've been in the field 30 years. And, we always focused on IgE, and we'll get into all this technical stuff. But it was really from the patients. I was getting calls all the time, and we'll get into this, about patients concerned about mast cell activation. And the more I looked into it and the more I researched it and saw your articles and some from a hematologist, Dr. Afrin, it started to really all come together. But I want to start today a little bit on a fun side. I'm always fascinated too. You're from Spain originally, and I actually had Dr. Alessio Fasano from Harvard, who was on my podcast back in September, who's from Italy. And I trained abroad for a while too. So I'm always fascinated. We'll just start out with a little bit of fun, sort of a two-part question. How did you decide to come from Spain for medical school to do your residency in the United States in pediatrics? And how did you end up in the field of allergy? So I was just curious of that. Take you back in time.
Right. So I'm going to correct you a little bit. I was already an allergist when I came here to the United States.
Oh, I didn't know that. Okay.
So what brought me here, I was actually doing with Antonio Ojeda, who was the chief of allergy at the Hospital La Paz in Madrid. I trained in Barcelona, my hometown, and I did my medical career there. And he had, to make it, in a nutshell, he had this conundrum of a little girl who have asthma, have tremendous anaphylactic events, who had hives all the time, and nobody was able to figure out what was happening. So I said, hey, Mariana, this is your turn. You're a first year fellow, just find that out. And it's like, wait a second, how can I do this? And then he told me, you have to be a detective. And I said,
right.
Okay,
That's what I love about allergy.
Okay. So I had a diary of the girl. What was she doing? What was she eating? Where was she? So when she was going through a field in the summer, she was wheezing through those fields in Spain, in the north part of Spain. Those fields have potatoes. And then when she was eating, she ate like some of the foods that had potato starch. So I started to put something together, 100 ingredients, and every one of them seemed to be kind of relating to potato. So I asked my boss, do you actually think she could be allergic to potatoes? And I thought, that does not exist. Nobody's allergic to potatoes.
That's what they always
Nobody's
say.
allergic to potatoes. And that's kind of what I really like when people challenge me. So that doesn't exist. It cannot be done. I said, okay, let's look at it. That's the way I was built, my genetics. And so I actually started to do that for, a very long story short. I discovered that potato is allergenic. It has low molecular weight allergens. And I actually published that for the first time in the Journal of Allergy Clinical Immunology.
Oh, wow.
And that attracted a lot of attention because I did what is called a Western blot. So I smashed potatoes and the peel of the potatoes and the flour of the potatoes, and I put in gels, and I was able to see that the serum of the girl had something.
Oh, wow.
That light up. But the most interesting part was the following. So I said, how can I prove that this is true, actually? So I got the serum of the girl, and I put it in the mother's arm.
Oh, right. That was the passive transfer, right? That was the old way.
I asked the mother, eat potatoes, and it light up like Christmas trees.
Wow. So that was the old, you could get away with that back in the day, right?
Yes,
Before HIV and hepatitis.
1987.
But that was the classic way. I trained at the Cook Institute in New York, Dr. Cook, who sort of originated allergy in this country. We're going to get into this passive transfer, where exactly what you just described was how they basically knew there was some type of factor, which we later learned was IgE, that is what triggers allergies. And that's fascinating. And so then you ended up coming
for me, what was really fascinating, not only was discovering what made it, but how could she be so sick, from wheezing, from hiving, from losing her blood pressure, from passing out. And the cells that I discovered behind that were the mast cells.
Yeah.
The mast cells have those powerful mediators that can do anything and everything from an itch to actually kill you. So that actually opened, my fascination to those cells. They are the most ancient cells of our immune system.
Right.
And I decided to just go and pursue, at that time I had finished my fellowship, but I pursue a PhD in the field of mast cell biology. And that's
was that in Spain also? You came to the United States for that?
I came to the United States. Larry Schwartz.
Yes, sure. He's in Virginia, right?
Exactly, in Virginia.
Yes.
And I did that by discovering that tryptase, the major particle of the mast cells, is in the nose when you sneeze.
Yes.
It's in the blood when you have anaphylaxis. It's in your lungs when there's a wheezing. Yeah. And that led, to my career in the United States.
Oh, wow. What a great story. That was even better than I thought. So we're going to move on. And we're going to probably get really in depth on a lot of things, but I want to always make sure that the listeners are enjoying this as much as I am. So mast cells, as you were pointing out, I think they were really a very overlooked cells. And I'll explain to the listeners what we mean by that. The field of allergy, I would say up to the 1950s, because again, I trained at an institute where there were a lot of doctors who, were very prominent in allergy in New York in the 1950s at my institute. And, they used to always tell me that, our specialty never got any respect. And one of the reasons was it was sort of considered a fringe, voodoo. We don't know what those guys are doing. I mean, even at the Cook Institute, and I tell patients, they laugh at these stories. People used to bring in their vacuum bags of dust. And at the Cook Institute, they used to take it, dilute it, spin it, do stuff with it, and inject it back into the patients. And understandably, our colleagues in the other field of medicine thought this was crazy. And then in 1967, I think the doctors Ishikawa, if I'm saying this correctly, at National Jewish, and a Dr. Johansson in Sweden, discovered that there was this immune globulin called immunoglobulin E for short, which was this mysterious factor that essentially allergists had been looking for years, that explained, why people develop allergies. So for a long time, I think in our specialty, there was understandably tremendous amount of attention given to IgE and everything that influences it. And obviously we know that mast cells are one of the cells that have these receptors for IgE. But I think in that process, we forgot to look at, I quote, the histology, that it's actually these cells that are very, very important. So I wanted to ask you what you think. I mean, obviously you're fascinated with mast cells. I've had on another podcast where somebody described them as patrol cells. What do you think their role is? I mean, again, also, that was why I think they were ignored, because people always thought, oh, it's the allergy cell. But people aren't just born with an allergy cell. A cell has to have a function, right? And the same way histamine. So what's your take on all these years of researching this? What is the mast cell, and why should we be concerned about it?
Yeah, so my fascination led me to kind of work with the people who actually have been like Rick Stevens, Frank Austin,
Oh,
the
yeah,
people
sure.
who actually have been at the core of a further understanding. But in essence, mast cells have been the more primitive cells of the immune system, and these Kurds, who are million of years separated from humans, have mast cells, and the
Wow.
reason is that when we were primitives and our
Right.
grandmother Lucy was in the woods, the mast cells used to protect us against parasites,
They did,
against
right.
scorpions, against venoms, against
Mm,
bee stings. So all of that, the mast cells have inside them, big granules. They
right,
release.
right.
Probably we will talk about histamine
Right.
mediators, all those things. And the important thing about the mast cells in humans is where are they located. So the mast cells are located everywhere. The whole skin
That's what I
has
think
mast
people,
cells.
right. I think even allergists, honestly, I mean, you're obviously a super researcher in this area, but I think even in my career early on, didn't appreciate that. I mean, it was like, okay, mast cells are in the lungs, they're in the nose, the skin, the allergy area, quote, the allergy areas. But to think about it in the brain or in the gynecological areas, this was so eye-opening to
Right.
me,
So
right?
essentially, there are mast cells everywhere. Like you
Right.
said, in the connective tissue, in the skin, in the
Mm,
mucosal membrane of the gastrointestinal tract. They're
right.
very important there, from the mouth to the tongue to the esophagus. So mast cells are located everywhere. And what we just recently had not appreciated, and it's been appreciated, is that depending on where they're located, they have different functions, and then they have different mediators. And so, the mast cells in the lung are more kind of simple mast cells, like in the alveoli, the breathing tubes. That the mast cells in the skin are bigger, they have more granules, and
Mm,
they have more powerful mediators. So what we call mast cell heterogeneity has just been unfolding in the last 3 or 4 years. Not mast cells
mm.
are created equal,
So
and they
that's an
are
important
everywhere.
point. Yeah, that's a really important point. And I'm going to ask you something now. Again, it's mechanism wise, but again, I think for my listeners, I'm going to try to make it really relatable. I had a professor at when I did some of my training at Columbia Presbyterian in New York, and he was really an interesting guy. He was actually one of the few board certified allergists and dermatologists in the country. It was back in the day, a lot of people could do multiple training and get certified, but he was just a very charismatic, interesting guy. And his big mantra was, you can't be allergic to something the first time, for example, that you eat it. So a lot of because it is perplexing to patients. Like, I've had shrimp 100 times. Why now did I break out
Right.
in a rash? And I always thought about that a lot, and I explained it to patients, but there is a little bit of a nuance to that because, with the mast cells, it does make sense. Obviously the classic picture of mast cells with the IgE, like looks like the Y-shaped receptors on them, has to have a certain amount of coating before they bind and release the histamine. But yet we do know people have allergic reactions, and we'll get into this for the first time, even from a vaccine. So what do you see as how to differentiate these, what I would say the mast cells being activated by an allergic, like an IgE mechanism versus maybe, I guess, a complement? Is that the other? Why would they just start to release? I mean, I know, for example, strawberries and codeine, those are what they call mast cell direct releasers. That you don't have to, it's quantitative. It doesn't have to be repeated. It could just happen on one time. So I know I'm talking a lot, but I'd rather hear how you see it.
Yeah, so I think that you're absolutely right that most of the time we have understood mast cells as cells that are reactive when they have been re-exposed many
Right,
times to penicillin, to a cat, to
right,
pollen. They have
right.
to, we said, 3 times you're exposed to the pollen, then you can react. But the mast cells, as I was mentioning, in the last 4 or 5 years, have been found to have a lot more receptors. So what you're talking about, that IgE, is that the mast cell has a receptor for that IgE, and then the receptors touch each other. We call cross-linking,
Right,
and they
bridging,
release
right.
the bridging and
Mm.
mediators. But there are many more receptors on the mast cells. And for
Uh,
example, there are one receptor that is called a kind of fancy name, MRGPRX2, that has been discovered just in the last 5 years. And
yeah.
that receptor makes people react to medications like antibiotics, for example, that are called
Uh,
quinolone, ciprofloxacin,
mm,
levofloxacin, and then also reacts people who react to general anesthesia, tracronium, rocuronium,
mm.
and they go through those receptors that are called G-coupled proteins. So they don't need to have an IgE on it. So some people have those receptors more
Yeah,
expressed
yeah.
or more available, and then boom, they react the first time they are
That
at
is
the.
so important what you're bringing out. And again, for the listeners, because I know this is so frustrating for them. It's frustrating for their doctors because, and I'm sure you've seen a lot of these cases because you do the drug desensitization program was it Brigham
At the
or
Dana-Farber, the Dana-Farber Cancer
Dana-Farber?
Institute.
Because, the patients that have those multiple drug allergies, it's one of two things. Their doctors think they're crazy, they're frustrated, and it's, it's very disheartening. And before, also up till now too, it wasn't possible to even test or figure out what was going on. So, but I think I think this whole thing with the mast cell helps explain that, because why are these people reacting to so many different medications, specifically antibiotics?
Right. So one avenue is like the penicillin. And I wrote a piece for the New England. So you have to be kind of exposed, several times.
That one, yeah.
And then there is also familial transmission. So we think that there
is genetics, right? Yes.
Some genetics involved in that.
Timothy Sullivan used to talk about that. That was his work at Hopkins.
And we haven't yet uncovered, the kind of the genetic kind of determinants of that. But then on the other hand, we have discovered more and more that, for example, mast cells have receptors for light. They have receptors for stretch. So some people, they exercise and then they have this flushing.
Right.
And so mast cells do have a whole cohort of receptors that are extremely important, that we're just like scratching the surface for that. Some people do have emotions and then they release histamine.
I'm so glad you brought that up. I have this paper right here from somebody in your state, Theoridis. It's hard to say his name. It must be Greek or something. But
he wrote him Theo.
Call him Theo, Dr. Theo. I mean, he wrote an article that was about the impact of psychological stress on mast cells, and really delineates, the mechanisms. And again, because, people are, again, the patients are frustrated. They're like, oh my God, like, why is this happening? I didn't eat anything that I'm usually allergic to. I didn't do this. And like the question, obviously, you ask them very carefully and sensitively, if you've been under a lot of stress, and they go, yeah, what does that matter? But it does matter.
Yeah, there is we are also unfolding connection between the mast cells and the nerve endings.
Right.
So that those connections. So there is interconnectivity between mast cells and a lot of the other cells in the body, and that's what makes the symptoms, very, very important. So one thing that I want to say is that it's hard to make a diagnosis of a mast cell activation disorder. Because,
we're going to get to that,
yeah, because mast cells mimic everything and anything.
Right. Well, that's what really frustrates doctors. When you look at the list, in a lot of these published papers of what the symptoms could be, the doctors throw their hands up, and I'm finding it more and more fascinating because, and again, patients are doing their due diligence these days. I mean, Google has become their new medical library, and and we're going to get to that because, again, I want to try to help them. But so, what I want to transition to right now, I'd like to transition to a disorder which is rare, but is very well defined. And I think we need it as the backdrop to that is mastocytosis, which I know you've done a lot of work on. So I have a list here, but I like to, and I find it fascinating, but what would you say is the most common clinical symptoms like with mastocytosis? And so actually, I'll tell you one other funny thing too. One of my mentors here in New York at Columbia had spoken to you a decade or two ago because one of the former supermen from TV had mastocytosis. And so what do you usually find? Because again, there's certain symptoms that would really surprise people, that.
Right. So I have to say that mastocytosis, when I started to do that, Frank Austin, my mentor, like in the early 90s, brought, 40 charts to my table. I was a first-year fellow, and he said, "Hey, Mariana, you're going to take care of those patients." And I said, "What do they have?" And he said, "Mastocytosis." And I said, "What is that?"
Right.
So then I learned, but one of the things that he told me is he says, the first time they have a symptom and the time where they have a diagnosis spans about 10 years.
Wow.
So I need you to shorten that time. And so I published in the New England Journal of Medicine about 6 years ago about a case of mastocytosis from a marathon runner. And the span of time was 9 years. We haven't made any progress. We haven't made any progress.
Well, it's tough.
But we know a lot more. So essentially, people can have symptoms that are non-specific. So essentially, that is what happens. People feel like flushing, feeling that diarrhea, feeling all those symptoms.
Right.
And the thing that actually is at the core now of this is that there's a cheap test that's called tryptase.
Yes.
Very cheap test.
And I think I think it's been underappreciated, because I think, as you mentioned,
totally.
and other people, that, I mean, as you know, like a lot of times they're saying now, even any patient that's had a venom anaphylaxis, maybe any patient that's had anaphylaxis, maybe they should be screened, right? Because they may be more prone.
Tryptase should be the friend.
It used to be a very
everybody.
hard test to get, though. I remember we used to have to send it to Larry Schwartz in Virginia, but now the major labs are all doing it, right?
Blood count, a CBC is actually more expensive than a tryptase level.
Really?
So getting screened for tryptase is the first thing about mastocytosis. And people who have mastocytosis have more mast cells in their body. It's not that they're more active; they just have more mast cells.
Right. That's a big distinction, right?
Right. And then a rash is the first symptom. So
I want to ask you two things that you published in a paper that I have here, which I thought also was super, super important. It was actually about mast activation, but it really probably could apply to, obviously does apply to mastocytosis, which was that I think people don't appreciate the GI symptoms. In a lot of cases like hereditary angioedema, which is another condition we see, sometimes that's the first presentation, because again, you're always thinking, oh, it's got to be an allergic kind of presentation. But when patients are having, like, as you mentioned, diarrhea or bloating or ulcers, things like that nature, the first thing they wouldn't start to think about is mastocytosis, obviously. But do you happen to see, when you look at the history, because you've obviously taken care of probably maybe more patients in the United States than anybody with this, do you find that GI is very prominent, and that, usually is...
So the secret for the mastocytosis is the two organ systems.
Okay.
So essentially, one of the major expressions of mastocytosis is having abdominal bloating, pain, diarrhea. But again, it has to be paired with some other symptoms.
Right. And
because the mast cells, are everywhere.
Right. They're not just so isolated.
Exactly. So having diarrhea is probably Crohn's, or is irritable bowel syndrome, some other disease, but diarrhea with flushing, with some other.
Right.
So again, the secret of making a good diagnosis is thinking about always like two organ systems.
I like that. Okay. And I'm going to challenge you on something else too. Now, this is kind of funny because I've been giving a lot of thought to this. My first day 30 years ago, so in the clinic, at Roosevelt Hospital in New York, before they would let you do skin testing, they say, look, check for dermatographia. And for our listeners, that's where we stroke the skin and we look to see if it hives up immediately. Like, the patients know this when they, let's say by accident, stroke their skin too hard with something and it wheels up. And I always say dermatographia means I could write your name on your back. And I want to ask you this, but we were taught that dermatographia is in 5% of the general population. But as you've published in studies and, that it's in 90% of the patients that have these mast cell mastocytosis or mast cell activation, which we'll get to. So do you think that's actually also a good crude test to just get your, because I've been, telling patients, to help, confirm along with tryptase, or even to think about ordering tryptase level. What's your thoughts on that?
So dermatographism, like you said, is like scratching the skin and being able to write your name there.
Right.
And it's like creating what we call a wheel and flare.
Right.
And that is due to the release of histamine and some other potential leukotrienes and prostaglandins there. And it's much more often seen in patients with chronic idiopathic urticaria and in other diseases. Right. So a dermatographism that is very exacerbated, so it happens every single day, it happens all the time, and that bothers the quality of life, I think is a good sign that maybe, and an association
mast cells are activated or excessive
all the time, and then associated with some flushing also, spontaneous flushing, not because dermatographism is like a physical part, so you have to touch it, but then associated with flushing can be a telltale sign that there is more activation of the mast cells. Definitely.
Yeah. Well, we'll get into this too. It's interesting because maybe a lot of the urticarial syndromes, especially all the physical ones, these all might be mast cell related diseases. Let me just ask, because I want to finish off on the mastocytosis, because they said it's a very well described but rare condition. So you normally would look at a serum tryptase level. Would you then also in the blood, if that was elevated, would you look at what's called a c-KIT mutation in the blood?
Right. So for somebody who has like symptoms of, abdominal bloating, some diarrhea, flushing, and then episodes of kind of feeling very dizzy and then kind of almost losing it, like we call it syncope or anaphylaxis. In that person, we would actually look at the tryptase level. And then we will do something that's called a KIT mutation. And the KIT mutation is the presence of the KIT is also on the mast cells and is the cause of the mastocytosis. There is a mutation, and the telltale mutation is called the D as David, 816V as Victor. So it's a specific mutation. And we can actually, without doing a bone marrow, we can have that mutation done.
That's what I wanted to ask you, because back in the day, it seemed like they were referred to a hematologist for bone marrow. So now that could be done in the blood.
In the peripheral blood.
Yeah.
And if it's positive, then we can, we had a woman who started to react to allergy shots. And then she was having those syncopal episodes, pretty severe. And then we stopped that. And then she started to have abdominal bloating and then diarrhea. And then she was losing it at home, young woman. And her tryptase was very mildly elevated, because if you look at the WHO criteria, it has to be 20, but her tryptase was 12. So we said, we did a peripheral blood mutation. It was positive.
Really? Oh, so you really went that extra step. Yeah.
I went extra step. And then we did a bone marrow biopsy, and she has systemic mastocytosis. And why is that so important? Because now she's protected. Every time she goes to have surgery, she can have her antihistamine. She carries an EpiPen.
Right.
So again,
yeah.
And those mast cells that are mutated react to specific and non-specific things. So again, people who have mastocytosis can also have like food allergies. They can also have environmental allergies.
Right. So they get lost. I had a patient that came to me. It was interesting. Who was getting repeated severe local reactions to allergy injections from another doctor, because I only do sublingual, and I think she had an anaphylactic episode too. And then finally, really she had switched doctors, and one of the other doctors before she got started again said, "Hey, before we give you any more shots," she was really smart. She said, "Let's get a tryptase level," and sure enough, it was elevated. And I actually was able to treat her with sublingual. So
I think let me just
sure.
the patient that I published in the New England, we published in the New England, nobody had actually undressed that patient. So the telltale of mastocytosis is looking for what we call urticaria pigmentosa. So when somebody has all those symptoms, say, undress. So when he came to my office, I said, okay, undress yourself. I want to see the whole body, the whole skin. And he said to me, but you're an allergist.
You're not a gynecologist or a urologist, okay,
or a dermatologist,
right,
or even a dermatologist.
Right.
I said, we need to. So that's kind of the other thing, the dots that are urticaria pigmentosa that don't go away. Those are the telltale.
Well, that's
signs.
also your European training. I'm gonna tell you why. It's really funny, because I trained in Israel, and they always told me a very funny story, because one of the doctors there in Israel was training at one of the Harvard hospitals, his fellowship. And, I guess it was back in the 80s, whatever. And, all the technology was coming out. And, they sent him to go see a patient, and he went there with a couple of the other fellows, not the older doctor, but not the attending, but the fellows. And he goes to the bedside, and he's putting his hand, checking where the chest wall is and listening very carefully, auscultation. And the other American cardiology fellows are looking at him like, what are you doing? He goes, we're going to do an echo in a few minutes. We don't really need to do this, and people really forget how much is picked up by still physically examining the patient.
How important is that? How important?
Right.
Like I said, this guy had been seen by 9 doctors when I asked him to undress. And he had typical.
Oh, he had the lesions. Yeah.
Oh, yes. He had urticaria pigmentosa limited to his upper thighs. But, if you don't take the pants down, you don't actually see that.
That's a good point.
I have a quick plug also, for mastocytosis. Men that react to Hymenoptera, bee stings, and then pass out are very likely to have mastocytosis. So this is something that we have discovered. It's like a subclass of mastocytosis. So men, all ages, who pass out after a bee sting, a wasp, that is potentially like 30% of them are going to have like what we call a clonal mast cell disorder and systemic mastocytosis. And that's very important, because those events are almost, life-threatening.
It's interesting you say that too, because again, somebody who trained me also said something very interesting. Like when I was an internal medicine resident in New York, and our hospital was right near Central Park. And then sometimes, in the summer, you would have a young patient come in, and they were hypotensive, and there was obviously, and sometimes they'd be having an arrhythmia or something terrible is going on. And of course, everybody's getting ready to shock them and, whatever. And one of my really good attendings said, be very careful, look at the body very carefully, check for any insect bee things, because again, like, one of the kids might have been working or stung in the park, here in the middle of New York City, but there's a park there, And when there's a park, there's bees and wasps and everything. And you don't treat that the right way, you're not going to,
well,
obviously.
and to follow up on that, EpiPen,
Yeah.
epinephrine, that really is really the important thing. And from this, if people wanted to take, two home messages, tryptase is your friend and epinephrine is your friend. So people who have had those episodes, they really need to talk to their allergies, to the primary care physician, to the pediatrician.
Right.
Am I a candidate for carrying, an auto injectable? Because what happens is when those events happen, the ones in the Central Park, we are not there. The doctors, we're not there. The patient is by itself. Right. They really need to be able 100%. To be educated and then inject themselves and know what to expect from that. So that I think is
that's a great point.
Critical. I mean, learning, from mast cells, I know how powerful they are, and they can actually wipe out the blood pressure in minutes. So somebody who's really, really healthy can become, almost.
That's always the most scariest thing about an allergy patient, right? Here you take a perfectly healthy person. It's not like an older person who's got heart failure. This is a young person in the prime of their life, and all of a sudden they're teetering, for their survival.
I remember, in Virginia, the first time I was in the emergency room with Larry Schwartz, this guy comes very chubby, 2 coronaries, and he has been stung by 20 bees, and he is like choking his throat, and we cannot intubate. And somebody is like, we cannot give an EpiPen to somebody who's cardiac. And I say, we are going to give 2 EpiPens, and we gave, and he had a little blip in his ST, but that's it. But he survived. He survived.
Right.
So
that's a great point.
Contraindication. There's no contraindication.
It's so interesting you say that too. I love when you bring up certain things. One of the most disappointing things to me is that so often when I've seen patients after whether it's a new patient after they've been to the emergency room, so few are given epinephrine for allergic reactions. I think I don't know if the staff is nervous that they're going to get an arrhythmia. I mean, even young patients, it's always Benadryl, putting them on steroids. And I'm like, this person needed an EpiPen yesterday.
Right now. So I go to the emergency room when I was a fellow with Dr. Sheffer, my other mentor, and I see somebody wheezing, covered in hives, and there is a drip like with Benadryl and steroids. And I said, how many Epis have you given to this patient? And they say, oh, Epi, no. And they have given a Benadryl and steroids. There's no indication in anaphylaxis for Benadryl or steroids.
Because it doesn't, and just so you probably know, to say the mechanism anyway. So the epinephrine really stabilizes the mast cell from secreting more of these mediators that are so dangerous.
Totally.
Let me ask you too, when we finish off on mastocytosis, because this is an amazing lecture for me. What do you do as far as treatment? Do you target the organ? There's no really definitive underlying like kinase inhibitor or something for this at this point, or is there? No,
there is. Actually, we have really good news. So the first,
is this new? I mean, I don't remember reading. Okay.
It's new. So the first plug is for the TMS, the Mastocytosis Society. Anybody who has mastocytosis should go on the website, because I am at the board of medical survivors, and that is really a good place for filtering information. Because you go and say, Dr. Google doesn't help. Yeah. You really need to have filtered information. So for people who have mastocytosis, I would like them to go to the TMS and to centers of excellence. And so now, starting there is one thing, when I actually started to do mastocytosis, Dr. Austin told me, they live 40 years. The life expectancy with the indolent kind.
Really?
Indolent systemic mastocytosis is a disease like rheumatoid arthritis or even diabetes, or so you can live, 40 years, 50 years with that. So treat the symptoms. Yeah. So I started to do that. And for 20 years, I did that. But, patient came back to me and said, Dr. Castells, I really don't go out too much of my house because I never know when I'm going to have diarrhea.
Right.
And people were coming back to me and says, I passed out and I was not expected to pass out. So we started to think about that. And I use something that's called omalizumab anti-IG for those patients. And we have already published that, and it really works. But in the last 5 years, I've been pushing around for companies that have what we call tyrosine kinase inhibitors. And for the first time in the last 3 years, we have clinical trials now with one of them. It's a tyrosine kinase inhibitor that blocks the KIT, and that KIT mutated. And that is a clinical trial that is now multi-center.
So it's not available yet, but it's on its way.
It is totally. And the patients who have mastocytosis can jump on those clinical trials. They are open. I have 2 clinical trials now at the Brigham, and there's multi-center. There's many, many other centers that do mastocytosis where the patients can jump into those clinical trials. And actually, the clinical trials are so fabulous that they can actually even clear part of their skin lesions.
Really?
So we are
Wow.
actually working towards children,
Mm.
because one thing that we haven't talked about is that, kids who have urticaria pigmentosa and cutaneous mastocytosis, by puberty, most of the kids are cured.
Yeah.
So that is
Why do you think that
really,
is anyway? Do you have any thoughts on that? Like, why does that happen? I mean, there's very few things in life. I mean, like they just kind of disappear.
well, it would be taking a longer conversation,
Okay.
but
Okay.
but the origin of the skin mast cells is different than the origin of the other mast cells. So there's two waves of mast
Oh,
cells.
so they
And
maybe.
so, and the puberty, the regulatory sites for those mast cells are estrogen, progesterone, and testosterone. So you can actually eliminate the clone. So we're working very actively at that.
Oh, that's really
And
fascinating. That's great to know for people listening. All right, let's move on to something too. To I guess the cousin of mastocytosis, mast cell activation syndrome, which again, as I said, 10 years ago or so or more, nobody ever even heard of this. For quite a while, a lot of doctors said, "Oh, this is just another diagnosis made up by the functional medicine community." The kind of diagnosis that the crazy patients, the ones that have brain fog, headaches, whatever, kind that I see for a lot of different reasons, who really suffering and have legitimate symptoms. So, how do you? I know you published on this a little too. So, how do you go about assessing these patients and differentiating from the mastocytosis, like that hematologic
right.
disorder, and versus the people that are just maybe don't have this? So what is your core things that you use?
Right. So in 1991, they meet, all I did not, but all the people who are doing mastocytosis in the world, from Peter Vallon, Dean Metcalf, Frank Olson, Larry Schwartz, everybody met there, and they made what we call the WHO criteria, World Health Organization criteria for mastocytosis.
Mm-hmm.
And they actually made a provision, and they said at that time, 1991, they said there might be patients who have symptoms of mastocytosis, and we can define them now, that do not have the mutation and do not have a bone marrow that has mast cell aggregates, because that needs, and they don't express what we call CD25, which is like the aberrant mast cells. And those patients in the future will need to be studied. And that was 1991. So at that time, that we recognize as a community that there are patients who present with flushing, with itching, with abdominal bloating, with brain fog, with wheezing, with syncopal episodes, or whose quality of life is not good, who might actually respond well somehow, and we can talk about what is the management of those patients.
I want to get to
but
that,
when we look at their tryptase levels, the tryptase might not be elevated to 20, which is the cutoff. And when we look at their bone marrow biopsy, they may not have mast cell aggregates, so they don't conform to the WHO criteria. So that's kind of backing down. Now, coming now towards here, we have actually several things. One is that what we call the non-clonal mast cell activation syndrome is a collection of patients who present the symptoms that we just talked, in which we measure three things. We measure the urine mediators, like and methylhistamine and prostaglandins.
Tell me about that. So you do find that to be helpful.
Very helpful.
And that's a 24-hour urine. You need
yes, and the Mayo Clinic is actually doing now without the 24 hours, so in spot urines. So we started to be able to.
Do they need to, let's say, be off antihistamines or anything? It doesn't really matter.
They don't. It doesn't matter, because the antihistamines bind to the histamine receptor. It
Okay,
doesn't bind to histamine.
Okay.
So they can continue to do that on antihistamines. And we measure those mediators in the urine, and then we measure the mediators in the blood. Like,
do you find that sometimes those are elevated where the tryptase is, like you said, somewhere still in a normal range?
Normal range, absolutely.
So that could be another helpful hint. Do you do both of them? The PG, I'm sorry, was it the PGD2 and the N-methyl? Was it
methylhistamine and methylhistamine? So we measure those mediators in the urine, and we found them elevated. And more importantly, we actually allow them to measure that when they are not feeling well. So sometimes, the mast cell activation syndrome is a disease where, there are good days and bad days.
Right.
And so we actually ask, okay, when you have your bad day, just go ahead and then measure your mediators.
Good point.
I have had patients, who I have carried for about a year. And at the beginning, I could find at baseline, everything is normal. And when they have their bad days, like 6 months after that, we have been able to measure and it's been elevated. And why is that so important? Because then we can do targeted therapy.
Well, that's what I wanted. Yeah, that was what I wanted to get to.
We can do
targeted.
Before
we get to targeted therapy, I just want to clarify one other thing too for the listeners. And so, again, clinically to making the diagnosis. And again, I was looking at one of your papers, which I thought was really excellent to explain. It's like so about 90% of these patients have abdominal pain, which again, as I said, might get overlooked. They would be looking for other GI issues like small bacterial overgrowth or gastritis, things like that. 90% of them you mentioned had dermatographia, where they stroke the skin or some type of flushing. And this I found very interesting too. 72%, again, and you surveyed, had medication reactions. So that's like another alert. When you have people penicillin or they start telling you 2 or 3 medications, that should set off the light bulb. Something's going on here. And then there is a confounding factor. If you look at that paper, I think it's the Hamilton paper. Yeah.
This paper says that over 80% of those patients are females.
Yes.
And that's a very interesting thing. And then also because there is also in the drug allergy, which is my second field of expertise, we also find that there is more females than males.
Yeah.
So again, why is that? Is it that the females, because they're exposed to ups and downs in the hormones?
Yeah.
They are recognized through non-self in a different way. So there's a lot of interesting things now, and the NIH is very interesting in studying, personalizing that to the females and further understanding what we call the inflammasome. Are we more inflamed because we go up and down all the time?
But a shout out to women, though. What? One thing I do say, I always say that, and my patients laugh. I always say that the stronger sex, because of course when they give childbirth. But obviously, COVID's proving that too. Women are definitely doing better than men.
For some things, it works. For some other things, it doesn't. There's a lot more women who have drug allergies, and there's a lot more women who have this mast cell activation, syndromes.
Let me ask you one other thing too, just before we get into how to treat this, because I know that, again, a lot of listeners really want this. But again, something that I started to learn the last year too is that sometimes also when you have this borderline elevated tryptase level, you may actually have this genetic condition called alpha hereditary tryptopenia, which is actually a lot more common
than we thought. It's called hereditary alpha tryptopenia, HAT for short.
HAT, yes, the HAT.
HAT for short. So this was discovered by Dr. Joshua Miller and Jonathan Lyons at the NIH in 2016. It was published very prominently in Nature Genetics, and they found that people who presented, with symptoms of flushing, of itching, but they also had other symptoms like POTS-like symptoms, maybe Ehlers-Danlos-like symptoms. They had duplication or triplication of the TPS-AB1. Which is the
genetic marker,
genetic marker. They also sampled the general public, and they saw that this mutation is very common. So 4% to 6%, and that's been replicated in the UK and some other studies have it, but they don't have any symptoms. So having it is not sufficient. So the majority of the people who have it don't have symptoms. So we need kind of the 2-hit thing.
There was a paper that said, though, the reason they like to check for that, let's say if somebody has a borderline elevated tryptase level before going to a bone marrow, but you're saying you don't have to do a bone marrow anyway now if you do the seed, if you do the blood. So can we avoid that? I mean, patients don't look forward to the bone marrow.
Exactly. So if we have somebody who has like a tryptase between 11.4, which is the normal range, and 20, which is kind of the mastocytosis, in all that gray area, we do the KIT mutation, the one that I mentioned, to rule out mastocytosis, and then we do the gene, something that's called gene by gene, so genotyping for hereditary alpha tryptosemia. So the HAT, and we do those 2 tests, and those 2 tests can be done by swapping the cheek. So we don't really need to do a blood test.
For which one? For the genetic one?
For the HAT, yes. For the
Interesting. Does that go to there was a lab that did it?
It's called gene by gene. Yes.
Or gene by gene.
And I don't have stakes on the lab, so
wow,
I'm not doing a plug for them, but it's the only one that we have.
Yes, I love doing when it has to come up with celiac, and I think it's obviously that is an area where genetic testing is going to be awesome. Right. Let me ask you, and then there's another area I want to go on to, but so in treating these patients, I'm gonna do like a little bit of a shotgun thing. Gastrochrome, sodium cromolyn, which again, hard to get sometimes. It's a liquid. You got to drink it. You find it effective. Is it good for GI symptoms with mast cell activation? So
we start from the beginning. We do H1, H2. H1, H2 antihistamines are kind of the first line. The second line would be leukotriene blockade, something like
Really?
Montelukast,
Okay.
accolades, Xaloton. The third thing would be prostaglandin blockade also, and we use aspirin for that. So
Really?
those are the
Oh,
three.
wow.
So we kind of target the mast cell mediators from the
Uh-huh.
histamine to the leukotrienes to the prostaglandins. And then we use what we call mast cell stabilizers, which would be sodium cromolyn and then ketotifen, which is like a mast cell stabilizer and an antihistamine. So those two are extremely helpful. And the sodium cromolyn, can be used from 100 milligrams daily to 800 milligrams daily. So it's like 2 vials 4 times a day or 1 vial once a day.
When would you use that? Would you use it if they're having a lot of GI or just in general?
So that's a really good question. So the sodium cromolyn has shown, in questionnaires to actually help with gastrointestinal symptoms, with skin symptoms, and with brain symptoms.
Really? So it does help with the skin.
And it's skin and then brain symptoms. So it stabilizes the mast cell across.
And would they need to do this before meals? I mean, it's important so it doesn't get,
Yes, 15 minutes for better absorption, not for anything else, just for better absorption.
Yeah.
And then we go at mast cell stabilizer. And then for people who do have like those anaphylactic events, we have been starting to use as chronic idiopathic urticaria, the omalizumab, the anti-IgE, the Xolair thing. So, and we have a paper by Dr. Giannetti, my associate in the Mastocytosis Center, the co-director now, where it's been extremely helpful. So it has stabilized, most of the people.
Very interesting. With that. Wow. What do you think about the classic desensitization? I do a lot of sublingual, which I found to be it works very smoothly. We don't get anaphylactic reactions. I've done this over 30 years. Actually, I'm doing it with the foods now, which I'm really excited about.
Yeah,
sure that works. Edward Kim, a friend of mine, a colleague, has done a lot of great work with peanut. But so what do you think about desensitization and obviously that's your center, but as a way of stabilizing the mast cell? Would that be, let's say, because someone says, oh, I'm terrible in the spring, or, there is some foods that are causing it. So it could hopefully shift that immune response to a more stabilized.
So we actually would like to stabilize all the patients through their IgE reaction. So if somebody has a food allergy, we said either you don't eat it or you get desensitized.
Right.
If they have allergies, which 20% of the patients with mastocytosis will have allergies, like in the general population, we said, allergy treatment, immunotherapy, vaccinations, whatever sort of that. And that tremendously helped stabilize the mast cell. So that is very helpful.
I'm going to ask you about a little bit of holistic stuff too here, because patients like to ask, and I find they say vitamin C, they say quercetin. Do you find there's any merit to some of those helping to stabilize the mast cells?
So what I say is like one size doesn't fit all. So because we cannot know.
Can't hurt.
It cannot hurt, but because we don't know our genetics, we don't really know our receptors. So I always say, somebody comes and says, I would like to try quercetin. I said, just try it for 3 months. So don't do it for longer if it doesn't help.
Right.
But trying doesn't hurt. And I totally agree we know less than we would like to know in terms of the patient's genetics.
Yeah. You want to know one other little secret, which you probably know, but I find this fascinating because I learned this many years ago from an allergist that was very unusual in Buffalo, Doris Rapp. It's funny. Q Sampson actually went up to see what she was doing because she was doing such interesting, unusual things. But back in the day, she used to treat food allergy patients with essentially sodium bicarbonate. Okay. And she called it Alka-Seltzer Gold because it didn't have aspirin in it. So I remember I actually went up to visit her myself once with my wife. She was a physician, to see what she was doing in allergy. It was just fascinating, And then I saw a paper from Japan, again, maybe about 20 years ago. This was really interesting. There was a patient that had wheat-induced exercise anaphylaxis. If he ate wheat, he was okay. But if he ate wheat and then he went, they exercised him, he went into anaphylaxis. You're familiar with that. Dr. Who was it? Sheffer. He's the expert on that. Okay. But anyway, in the study in Japan, it was a case study. I don't know why they thought of doing this. They gave him a very high load of sodium bicarbonate, I think like 2 grams or something. And he didn't develop any symptoms, prophylactically, beforehand. He didn't develop any symptoms. So I started thinking about what Dr. Rapp said, and then this. So what I was recommending for a long time to patients, especially the ones that had food allergies, like they would go to a wedding, a bar mitzvah, or someplace where they didn't know what was going to be in the food. I said, take 2 sodium bicarbonate, before. And as you know, it changes the pH, which again, it's chemistry, affects the mast cell releases. And then recently I saw a paper where omeprazole does something also, those proton pump inhibitors somehow affect the mast cell. So what do you think about that? I don't know if you've tried that, or you think it's an interesting
No, you know, in terms
thing?
of, I've been fascinated by the food trigger exercise induced anaphylaxis, and we've published with Dr. Sheffer. So you could actually sit in a chair, watch TV, and eat wheat. But if you actually eat wheat and then go run, then you have your anaphylactic events. And essentially is also the two heat. So the antigen per se is not sufficient. You need to change something in the body. And it had been said that, you know, the TTA, transglutaminase, was the enzyme that needed to be changed. And people release that enzyme during exercise. And that's why it changes the epitopes. But the pH also does the same thing.
Is it right?
So
it's
if
important.
And if you change that in one way or another, the absorption of the allergens is different, and the epitopes, or the pieces that are allergenic, do change. So again, I don't do that myself, but I think there's a lot of research that needs to go into that.
Yeah, I mean, I think it's fascinating. It's easy to do, and it's easy to do. I've even, like, Dr. Rapp used to recommend, even while patients were having a reaction. I mean, obviously, if you need epinephrine, you have to use that, but it's just so fascinating. Again, another way. And we're starting to realize, and I'm actually hopefully going to talk to Dr. Fasano again in a few weeks. He has a new book coming out called Gut Feelings. I mean, just how important the gut is to
Absolutely. But the good thing about that, the things that we need is control studies. We really need to do that in a way that we know that it's just not, you know, a placebo effect, that it's really, because people, I mean, and myself included, we think, oh, okay, this is going to help me. And it really, you know, placebo effect can be up to 30%. So we need control studies, and that would be really important.
Okay. I'm going to try to, I know your time is so valuable. I think I'm going to finish up on one last little area, which is not such a little area. And it's vaccine allergy. It's not something that we thought about a lot before. And I also have a paper that you just published with Dr. Phillips about maintaining safety with SARS-CoV-2. Now, I fortunately had my second shot. Thank God I did fine, but I don't really have allergies. But it is scary, you know, because you mentioned in the paper, you know, obviously we're having this mass inoculations going on now. And typically an allergic reaction to a vaccine is 1 in a million. So not too high. You know, reports now from the new Moderna and Pfizer vaccines, I believe, is about 11 cases per million, which is considerably higher. It's 10 times higher.
So essentially, I agree with you that this is kind of new. I mean, there's a new vaccine. I had my Moderna vaccine, second shot, like 2 weeks ago. I just fell under the weather for a couple of days.
If you feel awful. Yeah, just to warn everybody. But it gets better the next day, you know, but it's awful.
It's better. So essentially, we looked at, you know, all the Moderna and Pfizer anaphylactic events. So essentially, it is approximately 1 to 2 over 100,000, which is higher than other vaccines. But essentially, everybody who has had a hypersensitivity or anaphylactic reaction with 1 or 2 EpiPens, they have been out of the woods completely and very quickly and fast.
No, that's good.
So the treatment, and
you know, but you know what's scary? But I will tell you this is what's scary, because I don't know where you probably got your vaccine at the hospital, I assume. You know, I actually had to go. The second place was at like the raceway track here in Long Island. Like, it was like being online at a concert. You know, you're just winding through. And all I remember kept saying to myself, first of all, I brought along my own EpiPens. Really, probably not so much for myself, but if, you know, being the allergist on call in case somebody else needed it there. But it's a little worrisome. I mean, there's this mass thing going on, and God forbid there were 1 or 2 people going down.
And so we had made some recommendations for people who actually had severe food allergies, drug allergies, who actually carry an EpiPen. We recommend that they actually carry their unexpired EpiPen to the site.
Absolutely.
And then they're monitored for 30 minutes instead of 15 minutes. And then the real allergic people, we ask them to get, you know, an antihistamine, you know, their favorite antihistamine, 15 minutes before 30 minutes. Okay. So for really severely allergic people, you know, people who have reacted to foods. And then the other thing that's really important is that the polyethylene glycol.
That's why I wanted to ask you. You know, back in the day, and was it Dr. Kelso out in San Diego was always you know, he was like a big expert on this. But you know, so we're looking at the inactive ingredients. But do you think it's the inactive ingredients, or again, is it sort of this mast cell complement mediated something else mechanism, you know, especially when it's on the first dose, because it looks like it's on the first dose with some of these patients.
And most of the patients have never been exposed to, you know, something like a polyethylene glycol or, but there are actually also other patients who have actually been exposed to, like Miralax, you know, has polyethylene glycol. And a lot of people have been exposed to Miralax that have not reacted to the vaccines. So again, we really don't know how the vaccines induce those reactions. And the NIH is actually promoting a study to understand understand the mechanisms of those reactions. My take on that is that people, like you said, who have EpiPens need to bring need to be monitored for a little bit longer, and then need to take, their antihistamine, their favorite antihistamine, 30 minutes. And then the benefits of being vaccinated versus not being vaccinated are tremendous.
But would you say to a person that's had a, God forbid, an anaphylactic reaction to the first one to not get the second one? I mean, at this point?
If they had a true anaphylactic reaction, like I said, with a tryptase elevation, then potentially waiting for the second wave of vaccines, which will not contain the polyethylene glycol, we can contain, but we have a really, really minuscule amount of those people. It's like a handful, maybe 10 people for Moderna or 12 for Pfizer that have truly anaphylaxis on that. So definitely, if they have anaphylaxis, we kind of wait for the next wave. Now, the good news is that we have been following some of those with antibodies. So, Dwayne Weissman, a B-cell researcher, and they have found that with the Moderna, for example, I have a patient of mine is the first guy who anaphylaxed on Moderna here at the BMC in Boston. And he has really strong antibody titers to the spike protein.
Wow.
And so again, one dose might actually be sufficient.
That is right. That is the promising thing, obviously. So, wow, we have covered so much. I have learned a ton. I hope our listeners appreciate. I've been telling my patients for weeks now that I was getting the chance to interview, and I'm just so glad this came off. So, Dr. Castells, I want to thank you so much for taking the time out of your busy schedule to teach us all about mast cells and why they're so important.
Thank you so much. No, I wanted to finish on a an interesting note from my research. So the reason I got interested in desensitizing people, so my other life is to take people who have had anaphylactic reactions and say to them, you're going to be able to use that medication. And the reason we say that is because they have cancer and they want a chemotherapy. That's what we call the first line therapy. So we desensitize about 900 cases per year at the Dana-Farber now in the desensitization center that I have created. And now the next generations, they are actually coming to do that. And my dream is that every center, that cancer center, will have, an allergist or two that would do desensitization for those people. But then people also who have chronic inflammatory diseases that have a monoclonal or something that really helps them, we also want that quality of life. And that's what we really want. And the reason I got so interested, and I thought this was not like a kind of a moment of, okay, we can do this and not based on, it's because when I was a fellow with Dr. Austin, I discovered that mast cells have inhibitory receptors. So essentially, mast cells are cells that are ready to explode to give, tryptase, histamine, but they actually have inhibitory receptors that lock them into the mode where they don't react. And all the desensitization protocols that we have been able to produce are such that we lock the mast cells into an inhibitory mode. And I would like, all the, the people who actually listen to that, the modern allergies and all the new clinical immunologists to think about inhibitory mechanisms, a little bit like the immunotherapy for cancer. You kind of awaken cells that are kind of dormant, like the T cells that can now attack the cancer. This is the other way around. The mast cells are ready to attack. We shut them down.
Yeah.
So I just want to finish.
I am so glad you brought that up. I actually had this on my list. I just didn't know if we were going to have time, but I think it is so important. There are people that are truly suffering that have need help, with certain medications, and they have these, apparent allergic reactions. You are really one of the only people I know in the country that has such a center. And, sometimes I'm lucky I'm in New York, they can go up to see you. I've referred people. And yeah, it would be tremendous, especially in New York and other cities. And unfortunately, we know what's going on in allergy with the fellowships kind of shrinking and the whole field really in flux. I think it's such an important expertise. I hope that you'll do a course. Maybe I'll come up and do some training with you and other people in New York, because this does come up and it's very frustrating for patients. But yes, your center is really world-class, no question.
Well, as allergists and clinical immunologists, we can reach to all the other specialties. And that's what I think is really important, that a multidisciplinary approach. In medicine, we have the tendency to have silos. Yeah. But my tendency is the other way around, maybe, because I was brought in a place where you speak different languages, but you actually have to communicate. And for me, that's the only thing that works.
That's beautiful. And I'll end with a really funny story too. The head of my fellowship program, Dr. Greco. He was actually very well known because he was a head AIDS researcher. He was pulmonary. He's board certified in 4 different specialties. But he used to sit there sometimes and like moan a little bit. He goes, you know, the problem with our specialty in allergies is we don't have an organ. You know what I mean? It's like, you know, you're a pulmonologist, you have the lung, your cardiologist. And I remember him saying that, yeah, that's not good. But then, you know what, over the years, to me, like you being a detective, that's what I love about our specialty. I'm not held to any one organ. We have to deal with this whole body and be really good detectives and help our patients.
I was going to say, we don't have an organ. We have the language. We have the language to communicate.
That's most important.
And that's the most important thing. We can actually teach every one of the specialties.
You're right.
Your reactions to the medications are not toxic.
Right.
Those are immune reactions. The patient can go back to the medication.
Yes.
That was my first teaching to oncologists. Oncologists, don't even look at allergies until now. And now they look at us as like, oh my gosh, this is not a toxic effect of chemotherapy. No, this is an immunological effect. It's likely IgE. The patient can go back. The patient can be desensitized. So we have a universal language.
Yes.
And I think that's a really, really important for the next generations. We have a specialty that is thriving and should thrive because we can help everybody, starting from the patients.
Yes. Well, you're an amazing role model and inspire all of us, as allergy doctors. So again, thank you so much for your time.
Thank you, Dr. Mitchell. That was a pleasure to have you and be able to, to talk a little bit about, the passions that I have in life, from many, many years. Thank you. Thank you so much.
My pleasure. My pleasure.
Thank
you so much. All right, guys, we're good. All good. Yeah. Yeah. This has to be one of my favorites.
Thank you. Thank you.
All right. Well, I'll send you an email into into Sahar. She's been wonderful, by the way. Once it's released, it'll probably be released late next week. And we'll put up on the social media and all that stuff. Okay.
Thank you so much for doing that.
I hope we're in touch in the future. All right. Bye.
Yes. Bye-bye.